It is my pleasure to introduce this year's Goldberg lecturer. And as those of you who are here earlier this morning heard, Dr. Pemberton had questioned about how many years Stan has been at this course. Stan, if I'm correct, you were a fellow in 1962, and that may have been a year or two prior to that, as you were a surgery resident here as well, that you attended this. But I would expect that every principal's course since that time he has been at. So the exact number, not 81, but quite a few, John. Dr. Ian Paquette, one of our former fellows, as faculty here, it is always our pleasure, particularly at the time of the course, to welcome back to Minneapolis and St. Paul our former fellows. We're extremely proud of what they've accomplished, and Ian is no exception. Ian grew up out in the East Coast, out in Maine, where some of his family still remains, and he tries to get out there to visit family, and I'm informed that his brother, who's a pilot, occasionally will pick him up and fly the family out there, so that's a nice way to go, Ian. Ian attended University of New England as an undergrad, as somewhat of an overachiever, had a degree in biochemistry, biology, and math. From there, he went to Dartmouth, where he attended medical school. After that, he stayed at Dartmouth for his general surgery residency, but again, as an overachiever, spent some additional time in a fellowship doing research outcomes. Ian joined us in 2010 to do his colorectal fellowship. After that, he went back to the University of Cincinnati, where he has resided since. At present, he is an associate professor of surgery in the Department of Surgery at the University of Cincinnati. Ian has a number of things that we can thank him for. He's spent countless hours on multiple committees at ASCRS and within the American College of Surgeons as well. One of Ian's interests, as you heard from his talk, is practice guidelines, and he has really emphasized both to the ACS and ASCRS the importance of evidence-based literature to base those guidelines upon. Third, Ian has been on the editorial board of a number of different journals, most recently recognized by ASCRS with the Victor Fazio Editorial Excellence Award. So it gives you an idea of the quality and the effort that Ian has put in to each of these. And it should come as no surprise, having just watched the panel participate here, we should have probably put Ian in between Ann and John so he could referee that a little bit better. But one of his functions, and perhaps the thing that makes him most appropriate to speak on his subject this morning, is that he's Director of Surgical Quality and Safety at the University of Cincinnati. So as you could tell by his performance there, he deals with excited faculty and different topics from time to time and seems to help arbitrate that quite well. Ian, it is my pleasure to introduce you to the audience once again, or ask you to come up and speak. He's going to talk to us today on Beyond ERAS. Ian, thank you.
Thanks, Mike. I appreciate that introduction. It's certainly a pleasure of my career to this point to come back to Minnesota and get to interact with all you again, and hopefully teach you a little bit about how we can do things differently and how we can really achieve excellent outcomes. I was intrigued by the lecture by David Larson last night talking about how we could do things better in the OR, and I'm going to try to extend that to how we can do things a little bit better outside of the OR as well. So it's a pleasure to be back here. I like to think I was here in Minnesota sort of in the golden age with a lot of the excellent faculty that I got to train with, but I think that if you look at the history of this place, they've had probably a 75 to 100-year golden period that's still going. When I thought a little bit about the Goldberg lecture, this is actually a picture that was taken. I think Patrick Tawadros took this picture actually when he was a fellow here. Here's Dr. Goldberg in action in his clinic in Edina, and you can see he's on the phone. He was actually calling and congratulating one of his former fellows for doing something great. He's on his phone. He's got his computer going, and you see all the honorary fellowships and degrees, and this is really who Dr. Goldberg was and really still is at this point. So I wanted to honor that a little bit with the beginning part of this talk. I think it's interesting and could honestly be a talk in and of itself as to why we're all here and how we got here. If you look at the history, it dates back over 100 years with proctology training here at the university. And if I'm counting right, going back through some of the prior slides that I've looked at, there have been over 200, certainly close to 212 fellows that have been trained here and that have now gone out throughout the entire country and indeed the world that have spread all the words that they've been learned here. This will be my weak attempt to summarize Dr. Goldberg in one slide. And what can you say about somebody who has been the president of both the society and the board, somebody who has honorary fellowships and honorary memberships that are too numerous to count? I found the visiting, I'm sure that he's lost track of the visiting professorships over his time, but on his current CV there are 42 pages of visiting professorships. Just stopping to think about that is just amazing, to think about the number of people that he's interacted with across the world and the word that he's spread about colon rectal surgery. He was the first recipient of the Master in Colorectal Surgery from ASCRS and was also honored with a similar honor from the International Society of University of Colorectal Surgeons. So I think we all know the Stan Goldberg up above here. Here he is with Dr. Bernstein early in his career, and here's a more contemporary photo. But I think those of us that have been lucky enough to come here have gotten to know the Dr. Goldberg as a person. Here he is with his wife, Luella, and certainly they've had no small sphere of influence on the community and the world. And the neat thing about coming here and coming back here is when you do come to Minnesota and train here, you become part of the family of Minnesota. This is a Christmas card, holiday card that Dr. Goldberg sends out to his trainees, and you really do feel like you're part of the family when you come back. So I thought long and hard about what to talk about, and I could stand up here and lecture to you about any number of topics, whether it's what we just talked about, or rectal cancer, or Crohn's disease. But I realized that I can't really stand up here in the next half an hour and teach you too much that you don't already know about how to take care of surgical diseases. I wanted to talk about a lot of the things that I've learned over the past few years about how to do what we do and do it an awfully lot better and drive results that are second to none in your institution. I think Dr. Goldberg, I know him well enough that all this stuff that I'm going to talk about is a little bit on the fluffier side, and he's going to tell you, and I would agree, that the way that you get excellent surgical outcomes is that you have got to do excellent surgery. I think none of this stuff that I'm going to talk about really matters unless you're taking care of things in the right way in the OR. But a little bit about, I'd say this has been, at the very least, a journey for me. I had been in practice getting busy trying to do all the right academic things, and I was starting to get introduced into trying to improve the quality in my own department in the colorectal division, and got thrust into this opportunity. And my chairman of surgery said, you know what, you guys are doing a great job in colorectal. I'd like you to be the vice chair for quality and safety at my department. And it sounded great. It's a nice title, but I had no idea what that meant, and it's really been a journey trying to learn how to do this and do it better. When I started thinking about this, when you're talking about trying to improve any kind of surgical quality, we tend to look at things from way too far in the distance. We look at you take a measure, so let's take SSI rate, and we say that our SSI incidence is X, and we're going to make some intervention, and then lo and behold, it's Y. And I think if you miss all of those steps in between, you're missing the opportunity to actually make a sustainable improvement in this, and I'd like to show you how I've learned of a different way to do that. Shameless plug here. I happen to be lucky enough to be in Cincinnati, where we have Cincinnati Children's Hospital, which it depends which year you're measuring. It's a top 2 or top 3 hospital in the U.S., and they have a really advanced Center for Performance Improvement. This is actually some of the coursework that I took on this, and they have an advanced series. Anybody that's interested, send somebody from your hospital. You really learn a lot about how to make those processes actually sustain. So you do all this work, but the processes actually continue and your outcomes stay good over time when you stop putting all the work into it. So I'll put a plug in for that. This is sort of the 10,000-foot view that I was looking at things when we first got started on this, and I thought it was better than nothing. This is a sample. We had worked with our bio and informatics department at the university, and we had these scorecards that we had put together for every division. This happens to be the cover page of one of the ones we would look at back in the day with colorectal. I think it's important to measure how you're doing and compare yourself to others. So the black comparison in all these slides here is we compare ourselves directly to the regional powerhouses in our region outside of us, Cleveland Clinic, Ohio State, Louisville, Indiana, and UK. And I think this was a reasonable way to look at it as a snapshot in time, but we couldn't really dig into the processes and find out how to do better. So when I thought about this and I started taking some of that coursework, we got interested in length of stay. We heard last night at the Minneapolis dinner how much of a game changer enhanced recovery was. We thought we were doing this, and we had been doing it for a couple of years, and lo and behold, we had length of stays that were far too long. Patients were in the hospital about 6 days after a colectomy. We have a combined environment where we have a community hospital. Certainly the patients were a little shorter in the community hospital. The university hospital patients were longer. But I wanted to take this on and see why, because we had rolled out these pathways. We thought they should be working, and in reality, they just weren't. I'm going to talk for a few minutes, and I'm going to try to stay at a 30,000-foot view on this because, number one, it's fairly boring. But I need to just get some of this out there just so you can understand how we looked at our data. But looking at some of the things that I've learned in my process here, you have got to understand your health system. I did this in a safety net hospital like your Hennepin County Hospital and in a fancy private hospital. You've got to understand the psychology that goes into this, into changing people's minds and their opinions, and you have got to understand variation. So I'm going to talk very briefly about that and then show you what we did. The model for improvement is painstakingly simple. We figured out, what am I trying to accomplish? I'm trying to decrease length of stay. How do I know if I actually made an improvement? You can measure a number, but you have to sort of measure that number properly and understand that there's a natural variability to things and that you may just be getting lucky seeing a temporary improvement. And we do this by small-scale tests. I don't want to put too much into this, but I will say my take-home point for this part of the talk is don't just roll out some pathway where you're going to try to decrease SSIs or decrease length of stay. You need to look at every step of that process and figure out what's going to get the patient from your office to the discharge from the hospital in the safest way, and you need to break that down into really small-scale tests and test each aspect of it and hone in on what the successful outcome would be. And just to repeat, it is not just implementing a solution. We're surgeons. We want to fix things. So it's very easy to just say, I'm going to write out a pathway on a paper and put it out. That's what we had done a couple of years ago, and it just didn't work. So before I get into my part to show you what we actually did, you just have to understand variation a little bit. It sort of looks like this. We don't want to overreact to the common cause of variation. I put it this way. If you drive to work every day and it takes between 25 and 30 minutes every day, that's the normal variability of your commute. You're going to leave your house at least 30 minutes early every day, and you should get to work on time. But if you have a day here in the Twin Cities where you have a foot of snow and you show up an hour late for work because of a snowfall, that's really a special case. And the same things apply in surgery. There's an inherent variability to what we do, and we have to ferret out those special causes. So I'm going to blow this slide up a little bit. Instead of just looking at something and saying my length of stay is X or my SSI rate is X, look at it over time. So this is a way oversimplification of this, but this is sort of looking at it as a longitudinal process. Each blue dot is one data point in time. There's statistical software that can give you actually a control limit, so those red bars show you kind of how your process is functioning, and if you sort of plot your patients out over time, you'll see the results such as this. So you could look at this as that example. Your drive to work takes between 22 and 33 minutes per day, and that's sort of a better way to look at it. We need to look at those outliers. If somebody is outside of that control limit, there's a lot of statistics that go into this, but if points are showing up out of that control limit, that's something you need to investigate. Give you a concrete example here. So if you have a patient, just to help you understand some of our data a little better, if you had a patient with high blood pressure, this patient, those are individual blood pressure measurements in blue. Their blood pressure is always between 160 and 200. You make an intervention, such as treating with a drug, in this example an ACE inhibitor, and if you can achieve a condition where 8 of those points in a row are below where your mean was, you have actually shifted your process, and the process shifts down. You make another intervention. This is about as clean of a chart as you'll ever see, and I'll show you in a minute what we did with our own process. The last step before I get into what we actually did is you have to approach and tackle the solutions that will actually matter. So if you own a pizza delivery company and you're delivering pizzas late, there could be a number of reasons why that would happen. If you actually look at it in this way, though, 72% of the orders were late because either the driver got lost or they messed up the order. So if you can improve the process of the driver getting the right directions and your order taking, you've got 72% of your problem fixed. You can look at surgical problems and process problems like this as well. And in fact, we did with when we were trying to improve our processes. It's easy to try to fix some minute detail, but if that's not what's causing your problem, you're putting all of your effort into the wrong spot. So in summary, a little bit of the work that we did here, this is something that essentially I'll paraphrase it for you. We set a goal on the left. We wanted to decrease length of stay from 5 to 3. We had just picked that based on some literature and that we wanted to do better than what has been published. This was in the setting of us already doing an ERAS pathway that clearly wasn't working, and you can see in the middle there are some drivers and some interventions that you can make. But this is why we do this. Here's why you look at it this way. The data on the left side of this slide, this is our actual length of stay. So I showed you a number before we started with this, and the number was 5. So on average, patients stay 5 days for a colectomy. That doesn't sound so bad. But when you look at each blue dot being an individual consecutive patient, those results are not that good. And I think the reason you can pick the number, everybody may have a number in your head, how long it's appropriate to keep a patient in the hospital. But if we're doing the same procedure over and over again, there shouldn't be that much variability in the process. You actually see some patients towards the bottom of that really went home early, and then you have patients staying, anything within 12 days was sort of within the norm for us. I'm going to summarize about 2 years' worth of work in about 10 minutes here and just skip a lot of the details and show you what kind of results you can achieve with this. But the first was looking at why they stayed. I've got the word epidural there, but I think just to summarize, poor pain management strategies and poor surgeon utilization of the processes that we were supposed to do, and we saw that we could take on about 60% of that variation by fixing that. We had felt this was important to do, and indeed this is what we were trying to do. We had copied people like from the Mayo Clinic, and a lot of this came as well from some of the work that Connor Delaney was doing when he was at Case Western. Suffice to say, we had factors that we needed to get you the right processes before surgery, during surgery, after surgery, and on your way home. So we really had to collaborate. We needed the right processes in our clinic. We needed the right communication with anesthesia. The nurses and the practitioners on the floor had to be doing the right things, and we all had to be on the same page and get that process automated. If you kind of look at it in the sense of a process map, we just started completely over and made sure that we could absolutely optimize by doing these small-scale tests that we could optimize the process that we were using in our pathway. If you look at the right side of that slide, the end result, we got this all organized and got everything functioning as well as it could and put it into Epic. You have no choice but to use this pathway unless you want to manually check. So it's a default pathway. But the sort of the neat thing that we did that I talked a lot about at breakfast this morning is this. I'd like to spend a couple of moments on this. If you look at an ERAS pathway, we do a lot of things before surgery. We talk about nowadays the culture has shifted. We've gone back to doing a bowel prep, back particularly with the oral antibiotics, which we were not doing a few years ago. We give them pain medications before surgery. They get gabapentin and NSAIDs before surgery. There's some complex carbohydrate loading. We do a skin prep. We were able to take that. My partner found this. I wish I could take credit for it, but he found a specialty pharmacy in Kalamazoo, Michigan, of all places. And if I see one of you in my clinic and book you for a colectomy, you will get a box on your doorstep about a week before surgery. That box will have everything in it that you need so that you will get the same processes of care as the next patient will that comes through. It has the bowel prep, it has the oral antibiotics, the NSAIDs, the pain medication, it has the complex carbohydrate drink, and it has truly foolproof and idiot-proof instructions on how to take the contents of this package at 2 p.m. the day before your surgery. This has greatly decreased the number of patient phone calls that we get, and we think that this has been a game changer. So much to the extent that we even took this to our safety net hospital. We have patients that just can't afford to pay their portion of this, and we got our safety net hospital pharmacy to make bundles like this that we can send to the patients as well. So whether you can pay or not, you're getting the same process at my institution. little bit of the result. Here's why I gave you an introduction to control charts. If you look at down here towards the end, this is some data that went up to about June of this year. Proud to say that it's continuing in that direction, so that the length of stay, we were shooting for 3. We actually got it down to 2. And just as a reminder, we were doing all those things before. We were doing enhanced recovery. It just wasn't working. We actually have driven our length of stay down to a length of 2, and you see that upper control limit, that red dashed line. If somebody in my institution stays past post-op day 5 after colectomy surgery, there's actually some usually specific and identifiable reason, and I have those little circles on those points up there. Those were all, when we looked into them, there was actually some clear identifiable reason, whether it was they had a medical complication or they had high ileostomy output. But you are an outlier if you're staying more than that number of days now. So I think it's just, if you take home nothing else, you have to learn how to put these processes into motion the right way. Showing you the similar data in a form that we're most likely to look at, it's more familiar to us, just looking at it in aggregate. Again, the black line is all those great hospitals that I was comparing us to. The red line is us. And this is up through fiscal year 18. The FY 19 data is trending far better than that. And the great thing about it is you make impacts in other ways. So when you look at unplanned and related readmissions to the hospital, those have gone down every year, and they've actually gone down again this year, especially in comparison to those regional comparative hospitals that are doing the same thing as us. And then the other benefit that everybody gets from this is that it just costs an awful lot less if you provide the care in the right direction. So these are observed to expected cost indices, and we cost about half of what would be expected to do these procedures in our patient population. So I think if you do this right, it's a lot of work, but everybody wins. The last thing I wanted to close on with this is that if you do something like this, you're going to do an awful lot of work, and I promise you it will not sustain itself unless you take some measures to make these things be sustainable. So I heard David last night talking about how they've used these processes, and it's worked great at the Mayo Clinic, but they had some data that 17% of their patients didn't get their diet advancement, even though it was standard and it was ordered. And I promise you that you need to think about reliability of your processes, or these are all going to fall through the crack when you stop putting your direct effort on it. Getting back into some of the jargon, I think that most of what we do on an everyday basis is truly a chaotic process. The definition of what we're doing is chaos. I think in the best case, your processes are going to function at about a 20% reliability. We need to get to level 1 or 2. We're not talking about some of the manufacturing standards, Toyota manufacturing up to a level 6 reliability, but we're talking, can you get to a 1 or a 2? And that's sort of what we're looking for. I think level 1 is what we all tend to do, and it just won't work over time. So this is just by simply working harder. You can improve any process in any realm by just working harder and trying to put a pathway out there, and we standardize things. I would liken this to trying to improve OR turnover time, and I would challenge you that no matter what hospital you work in, and no matter what the situation is there, if you worked hard enough and fed back things and standardized things and trained people, you could at least temporarily improve the turnover time in your operating room. But if you're not continually working hard and putting all of your effort into that process, it's going to revert back. And even just doing these things, studies show that your process will fail at least 10%, if not 20% of the time, and that's while you're putting the work in. So there has to be some redundancy in the process. This is sort of the last point of the day, is that you have got to have a process that is redundant and will function without you putting all of your effort into it. Because if you can get some of these things functioning well, you need to be putting your efforts into the next problem that you need to fix. This comes with a lot of standardization, getting people on the same page, but also using the electronic record. You can have redundancy in the system. In our case, as they have at Mayo, the pathway is the default. Everything is defaulted into Epic, but you can have reminders, and you can use a lot of electronic redundancy, particularly to build into your system and feed back to the people that are taking care of these patients. And I promise you, if you don't, you won't succeed. If you do, you can get your failure rate to about 5% or less with doing these type of things. Take-home points, don't just implement a pathway. If you do that, it's not going to work. We did that. That was the left side of that slide. It just didn't work for us. You have to understand where that variation is coming from. find the components, test on a small scale, and you have got to make that process reliable in the long run, or else you're going to put a lot of work in and not get a lot of benefit from it. You can explore any avenue in the field of colorectal surgery or surgery in general. You can look at, and we are looking at things like readmission for dehydration after ileostomies. You can look at infection prevention bundles, clinic turnover, endo turnover, and you can even put some of these processes into care in something as different as cancer care. You have that rectal cancer patient that needs to come in, and they have so many steps of the process that they have to navigate to get to the right care at the right time. You can dive into it on a deep detail with some of these techniques and streamline any one of those processes. Sort of a lot of reading, many books more than this, but I put a couple of the useful ones up there along the way, and I think this is just the start of a journey, but it was eye-opening to me that we can do a lot better if we put the effort in the right place. Really appreciate the opportunity to speak today.
Ian, thank you for your thoughtful lecture, and thank you for all you've been doing to improve the care across the country. We have a few minutes before we break for lunch. I'd like to, any questions for Ian? David?
Ian, great talk. I guess my comment, and then I'll have a question. My comment is, it's really about building a culture of trust. It's trust so the nurse on the floor can ask the consultant why the patient's not on a protocol. And then the consultant can say, for these reasons, and explain them logically, or can say, thank you. Thanks for catching that, and we'll get them back on. And it's about building that internal trust so that you can build external trust, because that's our consumer and that's our payers. So the question I have is, since you have all this data on you and your competitors, have you been able to translate that into different things for contracting? Has that changed how insurers or payers of care look at your institution?
No, but you just gave me my next idea, actually. Because I think if you can do that and you can sustain it and you can show data that you can compete quite well, I think that's another step that we can take.
Yeah, so it depends on the payer, and it's probably even more appropriate when you talk about big companies. So one of the things that big companies, and I'll just use companies like Walmart, for example, they want to know that whatever door their patient walks through at Mayo Clinic, enterprise-wide, not just Rochester, they're going to get the same kind of care. So having standardized protocols across the enterprise is critically important to that. If you don't have that, then you can't build a contract. But having it certainly supports that objective.
So you talked about assembling a team. Did you have an enforcer, like somebody who actually makes sure that the protocols are being adhered to?
Yeah. So probably an oversimplification. You have to assemble multiple teams. Okay, so the first thing is you've got to have the buy-in at your institution, and you either have to have the personal authority and power in your position, or you have to have somebody directly supporting you from above that has that power and shares your vision. And I had the full buy-in from the chair at my institution for that. So I think for some of those higher level culture changes, you either need to have that authority yourself or you need some direct support. Forming the teams, you need to look at, in short, when you look behind the scenes, what I had to do was figure out all of those processes. So there was the things we needed to do in our clinic. There were the things we needed to do in the OR that really we needed some anesthesiologists on that part of the team. But then we needed the stoma nurses and the floor nurses on the team as well. So I don't want to have them all meeting and having, and the last thing you also want is death by a bunch of meetings. You can do this with a brief meeting. You can do this with a lot of just quick huddles and get people on the same page and then move on and go about your day because everybody's busy. So I think you have to assemble a few different teams. You don't need to get people involved in the parts of care that they don't directly take care of. But if you don't personally have the authority to make those changes or have the support from somebody with a strong voice above, you're going to struggle.
I mean, even with that, do you have like a PA or a nurse practitioner or a nurse who actually on a day-to-day basis is on the floor making sure that the patient is actually up and walking?
Yeah, but you have to Yes, but you have to put that responsibility for the people that are directly responsible for that part of their care. I think when you function as a high-functioning team, everybody has a sense of responsibility and pride in doing their part. So those nurses that are taking care of those patients are walking them. Everybody kind of has their part to play in this. I think the other thing that this empowered was we teach a lot of residents at our institution. If I have a busy day and I'm at another hospital and I'm not rounding until the afternoon, all of those processes can happen with it before I go and say hello to my patient that day. This stuff has all happened already and we don't have to wait. So it is helpful to have somebody who can oversee that, but if you can get buy-in from the people that are directly responsible for that process, it's more likely to happen.
Just one last thing.
Yeah.
And I'm asking that because sometimes you can have the nurse on the surgical floor, on the colorectal floor that are bought into your process, and then on that day, they are not there. They get a medical nurse who is filling in, and then things can fall through the crack.
Yeah, that's where you need some redundancy, which was one of the points I mentioned in the talk. So that's part of it. There is a direct nursing order. There's an order. Must walk this patient 6 times a day, whatever your choice is in your pathway. And then we have communication with the nursing leadership so that maybe if they get a different team member that day, the culture of that unit is to do that. We want the patients up. We want them walking. We want them eating early. It's hard to enforce that in practice. So I think that you need to have some redundancy on the team. All the team members, the residents are educated that way, and we're sort of all checking on that. And if I'm in between cases and I'm looking on Epic to see how my patient is doing, I'm looking to see if there are notes that they're being walked. We're sort of all taking some ownership of that process.
One of the surprising things is I looked at orders as actually a happy book of suggestions. It was not really an order because orders don't always get fulfilled. But empowering the patient needs to know what to expect. What is the patient going to do? So we actually write on a board in the room exactly what they're going to do. We write their dismissal day on the board, the day of surgery. We write these things so the patient knows. The patient can be their own advocate.
Just an excellent talk, and it's just nice to see us moving in that direction. This is a really minute, finite type of question. When I start looking at colon resections being discharged in 2 days, I start wondering when you do the records, when the records are done, do you put what time the surgery was done on there or when they were discharged or on what day? Because even 5 hours when you only go in 2 days is a 10 and 15% difference.
Yeah. When we keep track of it for this, just for our internal audit, we look at the number of days. So you could stay a couple extra hours, you get credit for another extra day. It's when you start going that short, it's probably useful to look at it in the number of hours. I will say, just for the culture change, the first part of the statement that you made, I wouldn't look at this as like a fast track thing. I'm not trying to rush some patient out of the hospital that doesn't need to be, but I think it's a mistake to try to cherry pick the patients beforehand. I think if you take even the patients that have a lot more comorbidities and problems going on, if you take and follow some of these pathways, they will still recover quicker than they would have if you can get them out there a little bit quicker. But I think when we start driving it as low as we are, measuring it in hours is probably a better way to go.
That was my question, cherry picking and exclusions
Yeah.
and, multiple operations, elderly, debilitated.
No, we do, and you have to modify a little bit. You probably don't want to give 300 of gabapentin to an 80-year-old lady. You may need to dose modify some of these things if they don't tolerate it well. But my advice is I try to follow these pathways in everybody. At the very least, their pain's going to be controlled better. They're going to be making an effort to have some mobility, and they will improve quicker than they would have. So I tell this to my pancreatic surgeons at my hospital. If you can get your Whipple patients out in 8 days instead of 6, it's not a next day discharge, but it's better than what it would have been, and the patient's experience is better. The hospital bed is opened up a little bit quicker, and there's a lot of downstream effects where people end up winning from this.